So, Brooke, who are you?
I'm a nurse. I've been a nurse since 2005. I worked in the ER and the ICU. Decided people needed more primary care and education and how to prevent all of these chronic illnesses and diseases I was seeing in the hospital. So I went back to school, became a family nurse practitioner in 2013, and loved my patients and loved helping preventive medicine and educating people. But I missed the hospital and the excitement there and was recruited back to work in palliative medicine. So helping people make decisions about their medical care or guiding families on making decisions about medical care. And through that process, people would come in the hospital and sometimes they would have advance directives, and those are supposed to help guide the family members on how to make medical decisions if the patient couldn't themselves. And we found over and over and over and over again that those were not helpful. And when I relocated back to Oklahoma, I thought about taking on the opportunity to do something with that knowledge and trying to make these documents that are so vital for people, to see if I could make them better. And so now part of my work is working in hospice as a nurse practitioner, but also trying to help people, guide them in making future medical decisions for themselves and talking about how they want to live. And then in my off time, I attempt to play tennis, not so great. And I have kids and a spouse that I like to hang out with, and we like to spend time outside and playing sports.
So, the Oklahoma Advance Directive you mentioned is what we're going to talk about mostly. We include in all of our estate planning, whether it's centered around trusts or a will or just what we call essential documents like powers of attorney, we include medical directives and the Oklahoma Advance Directive specifically. Mm-hmm. Talk for just a second about what the Oklahoma Advance Directive is, and then we'll talk about what maybe the issues or our solutions are to that.
I think first, not everyone knows what an Advance Directive is. Mm-hmm. So an Advance Directive is essentially two documents in one. It is your healthcare power of attorney, or the document that you designate the person to make medical decisions for you if you can't do so yourself. So you can't speak for yourself. You need someone to speak and make decisions on your behalf. That is your healthcare power of attorney. The second piece of that is the living will. And that is the piece of the document that shares, if you couldn't make decisions for yourself, you are in some form not yourself, not conscious, or just not decisional, how you would want someone to make decisions for you. Every state has their own guidelines on what language needs to be in that document. It is often very focused on the very end of life, if someone seems to be terminal. And in making medical decisions in the hospital setting, definitely, it is not always as black and white as we would like it to be. It's not always as easy to say someone is absolutely terminal or absolutely forever not going to be able to make decisions, or they're never going to wake up, or if we do X, they're going to die, or if we don't do X, they're going to die. It's not always that easy. And sometimes someone is just in a coma for a long period of time, and there are important decisions that need to be made about potential surgeries, potential risky medicines, and would this person be okay with the potential outcomes of certain procedures or medications.
Would it be fair to say that the Advance Directive is essentially giving the client a voice in a conversation that otherwise they wouldn't be able to participate in? Like if you're non-responsive and I'm your medical proxy, mm-hmm. I still want your input, but obviously in that moment I can't talk to you, and that document allows that to happen. Essentially, you're giving me your advice mm-hmm. at a point in time when otherwise you wouldn't be able to.
That is what it should do.
That's what it should do.
That is what it should do.
But it doesn't always do that.
It doesn't. I would say most of the time it does not.
Could I stop there for a second? Yeah. So I think one thing to clarify here that most people are surprised to find out, potentially, in my experience, there's a lot of the documents that we create in people's estate plans that are really our documents. We talk with the clients and we create something that's unique to them. Not everybody's trust is going to look and sound the same. Not everybody's power of attorney is going to look and sound the same. But the Advance Directive in each state is often what's called a statutory document. It's actually not drafted by the attorney or anyone else. It's primarily, or the core of it, is drafted by the state legislature. Correct. So there's a sense in which there's a lot of what's in the Advance Directive that we are stuck with because we don't have the ability to just come in and recreate that wheel.
It's state mandated language.
Okay.
Yeah.
Before we talk about what we do at Tallgrass to supplement that document and make it work better, what are the difficulties or the issues that you see as a nurse practitioner in a hospice end-of-life environment that document poses?
I would say in hospice, which is usually is not in the hospital, the issue is if someone cannot make decisions for themselves. They're either very confused or they are unconscious and there's a change in their health. Maybe they have an infection, maybe they have a fracture, they had a fall and a hip fracture. And do we need to do an intervention? And what is our hope with that intervention? And what would this person want? So in hospice, you're considered to be in the last 6 months or less of life. And what would be helpful is if we know what is important to them at the end of their life. What's important in how you are living? What do you want the focus of your living to be?
Quality of life kind of questions?
Yeah, absolutely.
And if we know that it is important for someone to stay out of the hospital, or it is important that no matter what, that they explore every single option available, regardless of how that affects their pain level or how it affects their ability to be at home or with family, whatever it is that's important to them as a person, knowing what that is can help family make decisions about whether or not should we send this person to the hospital or should we just manage their pain here and let them live here being whatever home is.
So one of the problems, I think, in part, and then you'll talk about how we fix this, specifically how you fix this, the document itself really provides people with a limited number of scenarios and options.
Correct.
Right? Where the language of the document is assuming we're only really making an end-of-life choice.
Yeah.
And you're saying oftentimes families are in a situation where there's some gray around what end-of-life actually looks and feels like. A lot of our clients think that the default is either just pull the plug or don't pull the plug, but the document is even written that black and white.
Yeah.
There's language where Congress allows you to indicate if you're non-responsive and you're on life support and physicians agree that there's no recovery, basically 3 options are given to you. You can either continue food and water but withdraw your medical support, withdraw all forms of life support, whether food and water or medical intervention, or keep me on every possible means of life support. And in some situations, somebody might be at a point where those are really the options. But I think what you see when you're talking about months worth of care for somebody who is in the process of dying, that leaves way too much to the imagination. For the family who's in a position to have to communicate those wishes to the physicians or the medical staff, they still don't really have much guidance just under the terms of that document.
Yes.
Is that fair?
My issue with it is because it's so infrequent that someone very neatly falls into those 3 categories of the Oklahoma Advance Directive of if someone is end stage.
Terminal condition.
If they're terminal.
Persistently unconscious.
Persistently unconscious takes many months to
Determine. Yeah.
to determine, correct. And so you're not always sitting around for many months just waiting to say, yep, we are persistently unconscious now. It's been 6 or whatever months.
Right.
What's more important and what is more helpful, regardless of where we are in that, and if we know exactly that someone's in stage or terminal, is what is our hope? What are we hoping by giving someone artificial nutrition and hydration or tube feeds? What are we hoping if we're putting them on different forms of life support machines, whether it's dialysis, whether it's IV medicine for our heart, whether it's a breathing machine, a ventilator. Whatever it is, what are we hoping for? and is that attainable given the scenario? And I think sometimes if families even knew what would be important to the person, to the patient, and then ask those questions, they would probably be able to make better decisions. But the hope is that we, with an advance directive that is more reflective of the person and what's important to them and their quality of life, that would give their decision maker or family or whomever it is, loved one, guidance on making decisions.
It sounds like one of the problems with the Oklahoma Advance Directive are all of the softer, more intangible questions that it leaves to the imagination. Things like the individual's hopes, beliefs, priorities, goals, desired outcomes, completely undesired outcomes. Those things don't have a checkbox or an initial here on that page.
Yeah.
But that's often the kind of noise that's rolling around in the family members' heads when they're trying to have to make decisions or disagree about what decisions to make. When it's not so much that they don't know whether or not mom or dad would want to pull the plug if they were at the end of their life, but as that's approaching, how do we handle care and quality of life decisions? So how does your counsel with our clients and your clients kind of fill in those gaps, and what does that end up looking like in how we treat the Advance Directive or what we end up giving the client in their estate plan?
So I do a consultation with clients to sit down and essentially talk to them like this. Just casually, let's talk about you, which I recognize. It does not always feel great to talk about yourself. So I tell people, think about it like a guided interview. I'm going to ask about you. And we just start out with, what's your own personal elevator speech? Who are you? So I get to know who they are as a person. And through many questions, ask what is important to them, what's important in how they live every day, what's the simple joys in your everyday life, and what's important for you to be able to do, and what do you think you could tolerate not being able to do, essentially.
Like the things that were, if these things were missing from your life,
Yeah.
that would make a noticeable difference to you.
Yeah. And a lot of us have thoughts on that. Amazingly, we don't necessarily know how to express that. And so my role in this is helping people figure out what it is, sort of what's our own personal line in the sand. And it's not necessarily something specific. Well, if I can't use my left arm, I'm out. It's,
Well, what are some examples of some actual clients have said, these are the things that for me represent the disappearance of quality of life?
It varies. And this is it's one of my favorite parts of learning about people and hearing who they are, and just how we're so unique, like snowflakes. We're individuals, right? I've heard anything from the breath of life is important. Doesn't matter. As long as I can be laying in a bed with the soccer game on, I'll be happy. Okay, noted. That's important to you, and we know that any care that we provide, we will make sure that you still have the capability of being able to hear a soccer game on the TV. To someone needing to be able to, I need to be able to at least sit in a wheelchair on the bank of water and be able to cast a fishing pole and go fishing, which, sounds very simple, but someone has to be able to have the cognitive abilities, right, to be able, and strength, right? Upper body strength to get in and out of a wheelchair, the ability to roll themselves to a pond, the ability to know how to lure a line and cast a line, and
have the dexterity in their hands and their arms and their upper body, and very, very little dependence on any medical machinery or technology.
Yeah, and even if, say, someone was in that position and they had use of their arms, they could potentially manage a feeding tube, for example.
Or an oxygen tank.
Yeah.
Yeah.
But those are things that I will bring up, is managing a feeding tube on your own something that's important or not. It depends on the conversation and what's important to that person. They don't always know. We don't always know, well, if this is what's important to me, that I have use of my arms, for example. I want to know, well, do you just need use of your arms for what? What do you need to be able?
For what is such an important question.
Right. Is it just like, I want to feed myself, or do you need to be able to make your meal? Or do you need to also be able to move yourself from a chair to a toilet or from the bed to the chair? Or would you be okay if someone's helping you? Because I have also heard, I don't want to depend on anyone to help me, or I would be okay with someone helping me.
So there's a
That's
lot of
so
just, like,
tough, right? Because almost every client that comes in for an initial consultation about just even their estate plan, they'll start by saying the same thing. I know within 5 minutes of most conversations, somebody's going to say something like, I just want things to be simple. Like, okay. Now in my head, there's 1,000 questions that come up there. What does simple look and feel like to you? Because that varies so widely between clients. Simple for this family is very complicated, whereas simple for this family is something that wouldn't even have occurred to these other folks.
Yep.
So taking that initial thing, I want to be independent.
Yeah.
Okay, great. Get that. But
How do you define
helping
that?
them articulate what that even means and what it doesn't mean. Oftentimes I find that clients get really surprised with themselves. Oh, I didn't even know I cared about that until I was pushed to really flesh that out a little bit.
Yeah.
So when it really does seem like for a lot of clients, when you push on that quality of life stuff, some of them have some very specific things in mind, but most of them have a general notion that what they want is as much independence as possible, and the more dependent they become, the less interested they are in living that way in any kind of a long-term.
A lot of times, yeah.
No.
A lot of what we're doing is fleshing out what that means to them. So
Social interactions.
Yeah.
Can I still go to church?
Yeah.
Can I still talk to my family or my grandchildren?
Yes.
Can I still play cards with my buddies? Can I dress myself? Can I toilet myself? Right? And as those things start to disappear, but those are, for different clients, those things there are different pressure points. So part of what you're doing is really helping to elicit that information.
correct. Yes. And help them, in my mind, a little bit is sharing the story of who they are as a person. Because the other thing is when they're in the hospital, the medical providers, the doctors, the nurses, the consultation teams, they're going to come in, and if someone is in a place where their advance directive needs to be used, we're thinking about what decisions need to be made. And the teams are coming and looking at this document. They're now seeing that this person has personality, that they have things that they've been doing with their life that they enjoy, they have values, and they become more than patient in room 286. They're now this person who likes to go fishing and walking outside and spending time in the sun and hanging out with their grandkids. Yeah, exactly. And so they know what's important to them, and they can use that in helping talk with the family.
Have there been some things you've heard people say that have caught you off guard or really surprised you as they've described what kind of quality of life looks like to them?
I think it's just more the unique things they've shared with me. I had a client who it was important for her, if she was injured, that she always had a lap for her grandkids.
Okay.
She could tolerate having below the knee amputation, but above knee, that would be her line. That would not be acceptable. She would prefer to have comfort care and live out whatever time she has left without
That's saving her life by doing a above the knee amputation.
Yeah.
Okay.
That would be for her unacceptable. And I have had patients in the hospital who had terrible infection in their leg. They needed an amputation. It would save their life. They could continue living. And this person, more than one actually, would not find that acceptable. Didn't want to live a life with an amputation and would rather just spend the remainder of their days slowly, essentially dying from this infection, as long as their pain was controlled, and going home and being with family.
I mean, that's such helpful information, regardless of whether or not that's what I would want.
Right.
If I were in a position to choose for that person and I didn't have that information, I would, of course, choose do whatever you have to do to save and prolong this person's life. Let's default to that.
Yeah.
And to have somebody clearly say, that's not what I want, puts me in a much better position to articulate their wishes rather than my wishes for them, right? That's kind of the key, right? We're trying to put people in a position to speak for you as you.
And
Not
to ease your
speak.
mind,
Yeah.
so that you can do that without guilt.
Yeah.
I would say there are many reasons that led me to do this. One of them was the number of family members or loved ones, not always families, could just be someone that was close to them.
Significant others, friends, yeah.
it was their decision maker, and they would come in, and the number of times I heard, I just wish I knew. I just wish they'd written it down, because the inner turmoil of trying to make essentially a life decision.
That decision for somebody is just, the people live with insomnia, shame, guilt, one way or the other. We've got clients who feel guilty because they chose to pull the plug, and others who feel guilty because they chose not to.
Yeah.
Right?
Oh,
or sometimes the tensions in family, when siblings are in a position where nothing is written down and there's no directive, and brother and sister are trying to make the call for parents, but they disagree with each other about what they would want. And then the months of emotional turmoil that's happening in that family as a result of what you chose versus what I would have chose.
Yeah, or infinite turmoil. I mean, the number of times I would...
never ending.
Absolutely. I would often play mediator more than medical provider in the hospital, and sitting down to help families try to come together to make decisions as a unit versus, pitting sides against each other. And that a significant amount of time was spent trying to help families come together. And it didn't always happen. It was very often people were angry, they were mad at each other, right? It's traumatic. They love this person who's there, who needs decisions made on their behalf, and they all love this person a lot, and they all feel they know this person well, and they feel that they're the best to make decisions for this person. And if this person had said, I want this human to make decisions for me, and here's what I want, this whole family could rest at ease and move forward.
The next Christmas would feel a lot better.
And they would probably all be together. Versus
they might still be missing the person who's passed away, but when you're counseling married couples, is it common for you to, as you start to flesh out this conversation, to start to realize that sometimes these spouses have very different feelings about what they would be willing to tolerate?
And yes, sometimes they have different ideas. We all have different ideas on what we feel would be our acceptable quality of life.
To the point where it's created any, have you had to navigate any tension that's created as like maybe a one spouse would say, I would want you to choose to end my life at this point, and the other spouse saying, well, I would never do that. I'm not going to honor that particular wish.
That has not been as common as I had no idea that's what.
So it's helped create a lot of understanding between people, probably having conversations they never would have had on their own.
Yes.
Right?
When the rare occasion has occurred that they disagreed, we always have this conversation, but even more so have the conversation, who is the appropriate person to make medical decisions on your behalf? Because even if in scenarios where the couples agree, there have been times where they felt that their spouse may just have a hard time, and they don't want to burden them with making decisions. And we try to always flesh out, what does being a burden look like to you?
That's another one of those, what does that mean?
Yes.
Things.
Tell me and so I will always
I don't ever want to be a burden to someone, but what I might mean by that is very different than what you might mean.
Yeah, exactly. So I will always, if they, I would say I define people's personal definitions of burden the most in our documents.
Even more so than like independence or quality of life, just that notion of burden.
Yes.
I think that's...
Everyone gives me their own definition of what they consider a good, bad, and unacceptable quality of life. Those are, in my mind, three very different things. So I always ask everyone that. But as far as just in conversation, when someone brings up, I don't want to be a burden, that's the thing that
I find that some people, when they bring up burden, are thinking first and foremost about the financial consequences of their care. I don't want to drag this out and increase cost if inevitably I'm going to pass away anyway. And they're thinking more about what they would consider a quote unquote practical impact on the family. And others immediately default to, they might care about that, but they're more defaulting to kind of the emotional regulation involved in that process. And it's interesting. You see that the most.
More so than even the financial. Because I think many of us we think health insurance will, that's a whole nother conversation, but we think health insurance will take care of it. And so most people don't know that there is a significant financial burden.
Because at some point, we've done this in guardianships where there was no advance directive and a guardian tried to prolong a family member's life past the recommendations of the hospital. And as soon as the doctors in the hospital agreed it was no longer medically necessary to keep this person on life support, insurance cut off, and they started amassing massive medical debt in that person's estate. So we've gone through the process. You've asked the client about good, bad, and unacceptable qualities of life. You've fleshed out questions about what does it mean to be a burden? What does it mean to be independent? What does it mean to sort of respect your values and beliefs and priorities and that kind of stuff? When we actually sit down and sign the estate plan, what is in that client's advance directive? I mean, we still have the statutory language, but then what else is there that we and you add to that?
It's essentially a larger document that includes sort of highlighted areas of their own little bio values, beliefs. So that includes religious beliefs, philosophical beliefs, culture, different cultures.
Sometimes specifically non-religious
Correct.
beliefs, right? Like if somebody does not want to have religious considerations be part of this,
Yes.
we need to make that explicit. And when
Yes.
others do, we need to make that explicit.
Correct.
I ask everyone about if they have a religious affiliation and if there's any part of that guides their medical decision making. So we include that.
We work a lot with Catholic clients and Muslim clients, and I think even some of those folks who participate weekly in their tradition are sometimes surprised to hear that their religious tradition does have some very specific guidance on how to make those choices. So part of what we do is offer clients our best understanding of what their particular tradition might ask of them, but certainly say this ultimately comes down to you, but to the degree that participation in this religious community matters to you, here's what sometimes they recommend in this. And it really is, I think clients, both religious and non-religious, are oftentimes surprised at the degree to which religious tradition and faith communities sometimes want to speak into this process.
Yeah.
Right.
And it usually does influence our medical decision making.
Everything from whether or not you want to be an organ donor to how long and under what conditions to remain on life support, whether or not it's allowable to remove a feeding tube, a lot of those things, yeah.
Yep, absolutely. So there is a section on that. We have a section on health experiences, our own experiences, whether personally or what we see on TV or what we've seen friends and family members, often will influence how we feel about medical care that we would want or not want for ourselves. Health priorities, as far as if we have specific requests or feelings on. I've had someone say, I would never want to be blind. I'm like, okay, that's important to know. Or I need to be able to use my arms, or I need to be able to walk, or I need to have a lap. Those are priorities for this particular person. And then we identify their definitions of quality of life. And then ultimately through this conversation, I have what's called medical goals of care. So we figure out what it is important for a person to consider their quality of life as living, and that they would continue to pursue all medical care available versus not. And so they're line in the sand, if you will. And so we have a medical goals of care. And that's ultimately, I wouldn't want a life less than being able to sit on the edge of a bank in a wheelchair and being able to fish.
And I want to be clear, we're talking about being that kind of explicit, right? I mean, the document, if the client says and gives an illustration of what they're talking about, that's included in what we're putting in that advance directive, right?
Absolutely.
So if they say, it matters to me to sit on the bank and fish,
Yes.
their advance directive says, it matters to me
Yes.
to sit on the bank and fish.
Yes.
Yes. If there's other parts of that that's important, we'll include that as well.
I remember having a client recently who got their draft of the advance directive that you had written, and they were surprised to see their own words on the page. Like, oh, I thought she was just going to take this and summarize it somehow, but this is what I said. And she wrote it down. So I think I want to edit that a little bit. But we give them the chance to do that, right?
Always.
Like
always.
if they say, ooh, I would word this differently in hindsight, but you got the point.
Yeah.
But we're really trying to listen in a way where we're if as explicit as they are being, we want to be that explicit on the
Absolutely.
page. Right.
And I've had clients where we didn't just quote, it was as if they wrote it themselves. So we just make it work for the person.
Which for some people that's important because it really is like they're using their voice to speak to their family, not using your voice to speak to their family, right? We're not trying to put this in legalese.
No, not at all. It's
We
very
wanna
much
be-
not.
we wanna be
or
clear.
medical.
Yeah.
And I include their medical history, just some of it, like a brief of it, so that sometimes that is important for their decision makers to have that information.
Have you had, so in medical history and what kind of care, not even quality of life, but what kind of care is acceptable? We try to be really frank with people, with family in our entire process about sometimes some struggles that the individual clients or their family members have. And oftentimes we get around to talking about things like substance dependence. Have you had clients who have a history of dependence who want to be explicit in their medical directive, for instance, that they don't want to receive certain kinds of narcotics or painkillers or whatever else because that's been a struggle they feel like they've had to overcome, and they don't want at the end of their life to be dependent on that again, even if it means experiencing more discomfort or pain than otherwise they would?
Yes, that has happened, and more so, I have had it shared that if I am terminal, if I am at the end of my life, then please give it all to me.
Give me everything.
Give it. Yeah. You know what? I've spent all of this time battling this.
I don't want to be hungry.
Yeah.
I don't want to be uncomfortable. Yeah.
Then please help me feel as good as possible.
I want to be having great fever dreams.
Yes.
Yeah.
And even people who've not had substance abuse issues have had concerns, expressed concerns about opioids. But I would say for the most part, many of us are afraid of pain. And so that is often shared. I don't want to be in pain.
Okay.
And that's important because there sometimes can be a balance of are you in pain, and do we want to manage, limit, be judicious with our use of
certain forms of medication and therapeutic alternatives. And
Yeah.
what kind of feedback have you gotten from clients after this process? So they've walked through this approach with you, especially if maybe they're updating an estate plan where they've done this before with the standard statutory language, and now we're asking them to have this very different conversation. Has there been any explicit feedback to you about what this part of the process has meant for them?
I have heard, wow, that sounded like I wrote it myself, where they feel like this is what I said, and you put it there. And I've heard surprise in, I didn't realize that this is what would be important for me, and where my line in the sand is, if you will.
So they've learned some things about themselves.
Yeah, absolutely. And hearing from their spouses or partners that they also learned something. And I would say most of all, everyone, you just see this like shoulder drop of like, I feel good. I know I have this thing that will help unburden my family or my people to be able to make decisions for me if needed. And on occasion, more so, I would say that's the most important thing. Mm-hmm. Not as often. Some are very excited or relieved to know that they have control. It's some form of control if they couldn't make decisions for themselves, that they would be able to have a say in that.
I mean, that's kind of the big picture for everything we do, right? I mean, clients come in here because they're worried about things that are out of their control. A crisis that leads to an incapacity or death. And they are anxious about what's coming. And it's the kind of anxiety that makes it difficult for them to actually live right now. Yeah. They're so worried about that they can't just be present here. Absolutely. And whether or not we're creating more of the financial strategy or putting in place the right fiduciaries to make certain decisions for guardianship over minor children or to take care of you if you become incapacitated, or even how to think about the value of your assets and what they're supposed to do for your family, getting really explicit and getting into the weeds with each individual client about what matters to you about this. Yes. The end result should be that weight off the shoulders. And not just, oh, I'm glad I solved that particular problem, but now that we've talked so much about that and we have a plan for how to deal with that, I feel so much more able to just put my eyes into what's happening right now and be present with my spouse, my children, my work, because I'm not worried about these other eventualities.
I was just thinking another thing that I talk with clients about is, once we sort of flesh out what's important to them and their line in the sand, I think what I have noticed is a lot of people are concerned that if they meet this, meet that criteria, that maybe everyone's just going to come in and pull the plug and that they're done.
Like this is requiring people to do certain things.
And you no longer can walk in, you're out. Yeah. And so one of the things that I always make sure I share with people is, yes, we often think of this document of an advance directive or a living will as, we're at the end of our life and this is how we want to die. None of us gets to decide, well, rarely, right? None of us decides how we die. We don't decide if we, are in a car accident or have a major heart attack.
Cancer diagnosis, right?
Yeah. Exactly. And so we don't necessarily get to have a say in how we die, but we get to share how we want to live. And ultimately, this is just sharing what's important to you and at what point you would want certain levels of care. So whether it's you're wanting to get surgeries and medicines and tubes, whatever that looks like, or you're at a place where that's not going to help you get from A to being able to sit on the side of the pond and fish. And if you can't do that, okay, well, now we're going to focus on controlling your pain and making sure you can be wherever it is you can safely be, hopefully at home or whatever's comfortable. But we're just shifting our focus of care. We're not saying we're not going to give you anything. What is our focus? Yeah. And not necessarily we're here to just pull the plug and you're out. It is whatever the remainder of your days look like, it's going to look like the way you want it to look, and hopefully a more comfortable way, with or without machines, whatever is important to you.
I love that shift in, instead of focusing on how to die, focusing on how we want